So welcome everybody to Special Education Thursday. This is our series of webinars / phone recordings that are diving into a piece of special education or a little nugget of special education and talking and finding out more about it as parents. So we are very basic here. We talk about questions that parents would want to know, but we also welcome professionals. My name is Molly Whalen, and I'm the Director of Parent Engagement at Advocates for Justice in Education, and we're the Parent Training Center for the District of Columbia around special education. The idea about Special Education Thursdays is we wanted to create something that was relatively easy to access and also allow you to pick up on topics that are of interest to you and find out a little more. We try not to overwhelm, but just give a little bit more information and also send you in some directions into the future. So we've had a whole bunch of different Special Education Thursdays, and I'm really excited that a longtime friend and colleague was willing to do this with me, Dr. Dan Shapiro, who's a developmental pediatrician. For many of you who know me or who've been on these calls, you know that I have 2 children with autism who have come up through the DC system. And Dr. Shapiro was one of the people that we met along the way, and I've always enjoyed being able to touch base with him. He's a wealth of information, especially for parents, and at the end of the session, I'm hoping that he will also share some of his parent programs that are available. But without further ado, Dr. Shapiro, and I'd love it if you just tell us a little bit about what a developmental pediatrician does and how you've been involved in this community.
Well, thank you so much, Molly. It's a pleasure to team up with you, and this is a great thing you've got going. So I am a developmental behavioral pediatrician and centered in Rockville, but I pop around to schools in the district and throughout Maryland and a little bit in Virginia. And I do assessment for mainly young children who have developmental or behavioral differences, kind of sort out where those differences are coming from, try to figure out what is the right level of support for each child, and support families along that journey. So today, I think we're going to be focusing primarily on medication management, but that's just a piece of what we try to do in supporting children. Usually medication management is not anything close to the whole package that's needed. We always combine it with behavioral care, educational care, and family support. So I guess, Molly, today we're going to be focusing on the medication piece, right?
Absolutely. And I think one of the things that we'd love to start off with, although I know you can go on and on, but I think for many parents, it's you hear about medications, or maybe even a school or somebody says, have you looked into medications for your child? And I'd love for you to start just there. What's a parent got to think about when something around medications, or if they have a child with, say, ADHD or something that might require or might find medications helpful?
Yeah, well, the 2 most common targets for medication management in children are ADHD-related symptoms, hyperactivity, impulsivity, and distractibility. And the second target that's most common is anxiety. We have medicine for other things too, but I think far and away those are the most common reasons to consider medication. And just because you got some hyperactivity and distractibility and impulsivity doesn't mean that you have ADHD, and it doesn't mean that you need medication. And just because you have some anxiety doesn't mean that you have a disorder, certainly doesn't mean that you need medication. But if any of these types of symptoms are really a big deal, they're in a significant way compromising a child's ability to be successful at school, at home, with friends, and it's clear that non-medical approaches just aren't going to be sufficient, then you consider a careful trial of medication to see if it might help your child. But there has to be very significant impairment across settings, over time, across different observers, in my view, to justify a medication trial. We don't do it just for an off situation here or there. It has to be an ongoing issue.
And then what's typically, or maybe more best practice wise, the first step? Are you approached by the parent? Does the school tell the parent to come and talk to a pediatrician? How does that work? Or how should it work?
There's no one way that's right. And, oftentimes it's the parents who are really coming to terms with this being more than just a phase, it being a significant problem for their child, and they might be the one who initiates a request for some evaluation. They might first approach their pediatrician. They might seek a referral to either a developmental behavioral pediatrician like myself or a child psychiatrist, in some cases a neurologist. But medications have to be prescribed by medical doctors, even though psychologists and other professionals know a lot about medications. We're the ones who at least for now, are the ones with the prescription pads. So it can that kind of evaluation can be initiated by parents. Sometimes teachers, though, will be the ones who are in a position to compare your child to other children and have that depth of expertise and experience that lets them be confident about the need for more than just ordinary care. And a teacher might, I hope respectfully and gently say, hey, we're kind of concerned about Timmy's ability to sit still and listen and be available for learning, or Joni's difficulties with being overwhelmed by anxiety, distress, emotional inflexibility, avoiding activities, and so the teachers might be the ones. Sometimes families are already working with professionals, occupational therapists, speech therapists, physical therapists, academic support, and it might be one of those specialists who are having difficulty making progress with the child because of either some self-regulation problems like ADHD or some mood regulation problems like anxiety. So really, I get referrals from all kinds of people, and it's good for folks to speak up and say, hey, is there more we can do to help? Just asking for a consultation does not commit a family to doing medication. The idea is just to talk to somebody about the possibility, and then together weigh the pros and cons and decide whether it's a good idea to try. But just going to talk to a doctor doesn't commit you to doing anything.
Mm-hmm. And what would be the things that maybe parents would typically see or triggers for them to think, maybe I do need to talk to someone about medications? Like what actual actions, or what's the child doing, or, what's worrisome?
Yeah, so if we're talking about ADHD, the impulsivity, distractibility, motor restlessness would be interfering with availability for learning in the classroom. It'd be interfering with the child's ability to participate in normal school activities, and the behaviors might be disruptive. If it's anxiety, the child, again, might be too shut down, too worried to be able to engage, and might avoid tasks that stir up too much anxiety. But it's not just about school. These are usually problems across settings, so that, on the playground, getting together with other kids, being able to interact in a normal way, if either ADHD or anxiety or other problems interfere in a very, very significant way with socialization, with family functioning. Just being able to get your child ready in the morning and ready at night, and being able to eat normally and have normal bathroom functioning and be able to sleep normally. Really, any of these things can be thrown off by some of these treatable conditions. I am focusing on ADHD and anxiety because those are the most common targets for medication management, but I need to say they're not the only ones. Children can have depression. Children can have severe mood regulation problems where they go up and down with their moods or are too explosive, and so on. So I'm glad to answer questions about things beyond ADHD and anxiety, but I'm guessing that most people who are listening in are listening because of those particular issues.
And would it be fair to say that if you're a parent and you're like, gosh, I'm hearing this problems in school, maybe not being able to focus or homework or whatever, but you're not seeing the same kind of unreasonable or dealable behaviors at home that might, I mean, is it fair to say, like, when you need medication, you're showing problematic behavior throughout a child's day? So it's at home and, in after school and in school and things like that?
Yeah, that's a great question, Molly. And it can get a little tricky. Certainly the child who's got problems across settings, home, school, playground, then it's easier to be sure that you need to consider doing more to help. But some kids will do better in one setting than another, but still have a pretty significant problem. For example, a child with ADHD might do better when they're at school if it's a structured school environment where they are told, hey, we're doing this, then this, then this, and there's a herd to follow. And at home or on the playground where there's relatively less structure, they might have a harder time knowing what comes next. Or it can be the other way around. Some kids with ADHD will do worse in school than at home because there are sometimes higher expectations or different expectations. Hey, you got to sit there and listen and sustain focus for this task. Where at home, the expectations don't require so much sustained focus. So the setting can really make a difference in how much trouble you're seeing, and it can go either way. Same thing with anxiety. Some kids have more anxiety in school because they got to navigate the social complexities there, get along with all these different kids and interact with their teachers, and they've got to do certain tasks that might make them uncomfortable, whether they're academic tasks or athletic tasks on the playground, what have you, and their anxiety can make them shut down at school, and the anxiety will be a lot less at home, again, where the expectations may be different or at least more tailored to the child's comfort zone. But then there are kids who have anxiety who are kind of holding it together all day at school because they really want to do well, and they do well. But then they come home and, it all floods out. They've been holding it together and all the emotion bubbles up and over when they're in the comfort and safety of their homes. And, you all can relate to that if you are holding it together at work all day long because you've got to perform there. But then you come home and, you can show your emotions more when you're back in safe harbor. So it really sometimes is across settings, but sometimes for these reasons, you see it more at home or more at school. Go either way.
And let me ask you about kind of age or typical time that you would do these. Is there a better time to do medications like this for students as far as their age?
Well, it really is individualized. Generally, the more severe the problem, the earlier we consider treatment. Now, for ADHD, medication should be considered a first-line treatment. And, if the ADHD is significantly impairing, For example, if a child's been kicked out of their third preschool program because they simply can't focus, you might treat a preschooler if it's going to change their whole academic path and influence which school they might be able to even go to. The milder the ADHD, generally the less impairment there is in preschool and early elementary school. It might only become a problem as academic demands increase, and some people with ADHD aren't diagnosed until they're in college or facing other adult challenges. So it really is a matter of degree. Anxiety is a different story, where we do medicine first line for ADHD. Anxiety, the first line treatment, really should not be medication unless it's very, very severe. With mild to moderate anxiety, we usually start with cognitive behavioral therapy, a specific type of talking therapy, and usually that helps. If it doesn't help enough, or a child is just even too anxious to participate in therapy, or there aren't therapists available, sometimes then we'll go with anxiety. Go with medication for anxiety. If you can't really help a child without it. So medicine first line for ADHD. Medicine is not first line. Cognitive behavioral therapy is first line for anxiety. And whatever age it's clear that you need it, that's the age you talk about it.
And then tell me a little bit about what the medication looks like or does. Like, are there side effects, and are we talking like a pill a day, or is there something more?
Yep. So let's assume that the diagnosis of ADHD has been carefully made by an expert, and parents and doctor agree that a medication trial is in order. Then there are two families of medications for ADHD. There are stimulants and non-stimulants. Stimulants you've probably heard of are Ritalin, Adderall. There are others like Focalin, Vyvanse. These are the brand names. There's a whole bunch of them. And stimulants work really, really well if you can avoid side effects. You get a tremendous benefit when the kids don't have any problems, but there can be side effects with stimulants. It's an individual thing, and there's no way to predict who's going to have side effects and who doesn't. But you start with a very low dose, generally one dose in the morning, and see how long it lasts. There are long-acting medicines and short-acting medicines. Most of us prefer to use long-acting medicines that can be given just once in the morning and hopefully get a child through their school day. But these medicines come in all different forms now. There are pills that you can have your child swallow if they can. There are capsules that can be swallowed, or you can open the capsule and sprinkle the beads onto soft foods like yogurt or pudding or chocolate syrup or peanut butter or whatever. And then there are now some newer long-acting liquids to go with the shorter-acting liquids that we've had for a while. And there's also even a patch for one type of medicine that can be put on a child's backside, and the medicine absorbs through the skin. Takes a while to kick in, but it's nice for kids who really can't tolerate medicine in their mouths or swallow it. So all different forms, and I generally ask parents which type they think their child would do best with. And then it's once in the morning, and we start with a very low dose and gradually increase. And Molly, I believe you have, for people who are watching on, a blank medication trial form that I sent your way. Is it possible to put that up for people?
I pulled that up so people who are on the webinar, and then of course for the recording, will get to see it right now. So it's on the screen.
Okay. So this form shows one way of doing a trial, where the target symptoms are listed on the top half of the page. That's blank on your form there, but you could fill in the target symptoms. For example, for ADHD, you'd have things like hyperactivity, impulsivity, distractibility. You might also have things like difficulty learning, difficulty getting along with peers. You might also have things about being organized, keeping track of your stuff, keeping track of time. Whatever problems seem to be related to the child's ADHD and you'd like to see better, those would be listed as target symptoms. And you'd put a number next to each target symptom. If it's not a problem at all for the child, you'd put a 0. If it's a little problem, a 1. If it's a medium problem, 2. And if it's a big problem, 3. And the idea is when you start a medication, you're hoping that those 2s and 3s, the medium and big problems, turn into 0s and 1s as a result of being on medication. Meanwhile, as you're introducing medication, you're not just monitoring for improvement in the target symptoms, you're monitoring carefully to make sure that there are no side effects. So you'd list possible side effects on the bottom half of the page. And for stimulant medications, you'd list things like decreased appetite, trouble falling asleep or staying asleep, tics, which can be jerky muscle movements like blinking or nose twitching, or vocalizations like throat clearing or grunting, which can happen also. You can also, with stimulants, have changes in personality. You can be more subdued, you can be more irritable. So there's a whole list of side effects that can happen with stimulants. The good news is that there are no hidden side effects with stimulants. And if there are side effects, you can just stop the medicine and they go away. You're back where you were, same old kid. Mm-hmm. So it's a good idea if you're going to do a trial to keep track of both the benefits of the medication and the possible side effects, first at baseline before any medicine, and then as you gradually increase the dose, if you get into side effects, the numbers on the bottom half of the page go up before you get any improvement, before the target symptom numbers come down. If you get into side effects before benefits, then that's a bad medicine for your child and you throw it in the trash. First, talk to your doctor and make sure we can't make some adjustments. But that's not giving you a good feeling then. And you might then try a second stimulant medication or even a non-stimulant, a different family of medication if side effects kick in before benefits. If, on the other hand, you're increasing the dose and nothing's happening, then you keep increasing the dose under a doctor's direction until something does happen. Hopefully, you get into benefits before side effects. The 2s and 3s for target symptoms are coming down to 0s and 1s, and none of the numbers on the bottom half of the page, the possible side effects, are going up. Mm-hmm. So good stuff happens before bad stuff, good medicine. Continue it, maybe do some fine-tuning, see about the timing, etc. Super tuning the dose, and that's what you want to see. So and then there's all sorts of phase 2 things just to cover the day best you can to maximize the benefit of the medicine. But we won't go too much into that right now. Mm-hmm. But that's in a nutshell how you can do a carefully controlled trial with stimulant medication, with parents observing, teachers observing, filling out these forms. And for children who are old enough, I like the kids to do self-ratings where they do a baseline rating and they fill out the same form. A fringe benefit of a medication trial is maybe for the first time a child is stopping and thinking, well, how am I doing with this stuff? Mm-hmm. With these types of issues, and some self-awareness can really be a nice thing for a child to have, and it can help them maybe feel more in control of their lives and feel like they're being helped take some of the mystery out of the difficulty for the child.
Of course, I probably should have known that this topic would go probably beyond our time, so I'm keeping a tight watch on the time. But the last I asked for you, and you kind of touched on it, especially since this is kind of special ed Thursday, and is what recommendations do you make to parents on how to communicate with the school, especially I would imagine during this trial piece? Like, what are there some things that you always say, hey, make sure you do this, or how do they work as a team together, or should be?
Yeah, I think these forms can be very useful, a good starting place where, hey, teachers, we really value your input. You're the ones who are going to be observing the child Monday through Friday. Parents can observe on weekends and vacations, but these stimulant medications anyhow kick in the morning, and then they kick out usually as school is ending, if not before. So parents may not have an opportunity to observe the effects of medicine directly except on weekends. So we really need the teacher's input, and I just explain it to teachers the way I do to parents, that we're going to do a trial. Here's what we look for. We set up a system of communication, faxes, secure emails, etc. But the teachers are not to be making decisions about whether to use medication or not. But we sure need their objective description of what impact the medicine is having. And sometimes a meeting at school or a telephone conference with teachers is extraordinarily helpful, answering teachers' questions with parents' permission, just as important as answering parents' questions. Get everybody on the same page.
Right. And then I'm going to, if you muted your phone and you have a question, you can certainly ask it, and I'm checking the chat. I don't see anything, but Dan, where would you suggest, everybody knows that who've come with Special Ed Thursdays knows that I always try to end with, if you want to get more information, what's one or two places to go to get more information? So I guess I would ask you, hey, if there's a parent listening now or later and is like, I think we may have a problem, where do you suggest they, especially thinking DC, go for a first stop?
Yep. So, always for referrals to experts in medication management, I would recommend you start with your primary care pediatrician. Okay. They're going to know your local resources well. Every pediatrician, I'm sure, has a good working relationship with a number of child psychiatrists that they trust. There aren't too many of us developmental behavioral pediatricians, so we're not a reliable referral in terms of our closed practices, but child psychiatrists are more numerous. So I'd check with your pediatrician. In Greater Washington, we are so fortunate to have the Children's Hospital, the Georgetown University Hospital, NIH runs studies that are often free, that have world experts setting up medication trials. Some children might qualify for some of those studies. And then up the road we've got Kennedy Krieger. So if especially insurance coverage is going to be very, very important to you, going to one of these academic centers can give you better insurance coverage than most people in private practice do. But I'd start with your pediatrician and other parents who might have had some good luck with a doc, and see if you can come up with a short list of folks to call. And the big problem these days is availability and affordability of resources. So it's good not to put all your eggs in one basket when you're looking for referrals. Try to get a number of names, because you're probably not going to get lucky with the first phone call you make. I'd encourage you to patiently work through a list, and your efforts will pay off.
Well, that's really good advice. And can you, as we finish up, I'd love for you to share a little bit about what you do for parents kind of year-round.
Well, thanks, Molly. And largely to answer this huge problem in our field with affordability and availability, I thought we need to do something different. So over the years, I've created a parent group training program, strength in numbers, called Parent-Child Journey. The website, parentchildjourney.com, has a list of parent group training offerings. There's a 10-session so-called Journey program, which is a systematic approach to behavior management for children, where parents get together once a week in the evenings, different venues around town. It's pay what you can, and we really mean it. Parents who can pay more, we appreciate it. If they can support folks who can't. And the model has worked out very nicely. And so there's the 10-session boot camp, if you will, for behavior management training. And then there are special topics where we just do, one topic per night. It's not a 10-session program, but you pick and choose what's of interest to you. So those are all listed on the website, parentchildjourney.com, pay what you can. So thanks for letting me get the word out on that, Molly. I appreciate that.
Well, we appreciate you being so part of the DC community and metro area. And I know this is just one little nugget, the medication piece, but that can be really scary for parents. So hopefully, if the parents find this recording and listen, they may get a little bit of information and have an idea of how to ask and where to go. And it should be, as you've said before, kind of part of the whole communication plan and working towards. So doesn't sound like we have any questions in the chat. Most people like to listen in, and that's okay too. So I just want to thank you so much, Dr. Shapiro. And again, it's parentchildjourney.com for the parent training and boot camp, and it's a pay what you can. And we'll tweet that out as well as we put out the recording today. So if you're interested, take a look. And thanks again. Bye, everybody.
Thank you.